At Akros, we really like to keep things very tactical and practical. We are very founder focused. And so this is really made to bring things down into very simple terms. And why I'm really excited about this particular webinar today is because we are focusing on the solutions and not just the problem anymore. I've been going to Health and Vive and all these conferences for the last decade, it feels like. And a big frustration of mine is just being so focused on the problems and not spending enough time talking about solutions. So that's what we're doing different today. And I'm really excited to have Saran join me for the conversation. So without further ado, my name is Demi Radeva and I'm the CEO of Akros Advisory. I founded the company after spending over a decade in managed care organizations. And for the majority of my career, I was in strategy, innovation, and truly in the buyer role of purchasing digital health technologies and solutions. And so that is the lens that I'm bringing to the conversation today. In one of my last roles before I created Akros, actually was Senior Director of Medicaid for all of United Healthcare's plans. And so today we're talking about Medicaid. It is a space that I'm very deeply passionate about. And we're going to share some insights on what the HR1 changes really are going to mean for the states, for the managed care organizations, and for founders as well. And Saran, I would love for you to give us a brief bio as well.
Hey everyone, I'm Saran Tao. I'm the co-founder and CEO of Mirza. We are effectively a TurboTax for the social safety net. So SNAP and Medicaid work requirements are certainly right up in our alley and feels like an important thing to be helping to address.
Lovely. Awesome. So what the objectives for today are really to create shared clarity on HR1 and what's changing, to really provide a high-level overview of the risks that we're about to experience across state, managed care, and vendor organizations, and to provide you with a practical readiness roadmap. So there will be a few 30, 60, 90-day action plans that we'll share with you at the end. And then we also have readiness roadmaps available for state representatives, managed care representatives, and vendors as well that we can send out after the presentation today. So happy to share that with you. And then it's really to highlight a credible solution path that is going to align with what states and managed care organizations are going to need as the HR1 policy comes into play. So what is HR1 or the Big Beautiful Bill? It's really a sweeping package of tax and social policy reforms. It was signed into law on July 4th, 2025, and at a high level, it really does everything from increasing defense spending to really reshaping Medicaid and all types of other social benefits. CBO actually estimates that the law reduces federal Medicaid spending by about $900 billion over the course of 10 years. And the new work requirements that are part of that law are the single largest source of savings. They're coming at about $330 billion of savings from that. And so for our audience today, folks that work within payers, employers, benefit administrator organizations, and or vendor solutions in the space, a key area for you to watch is the work requirement verification mandate that begins in 2027. So that's where we're going to be spending a lot of our time today in this presentation. It's not meant to be a full discussion of the full law or anything like that. That's truly our focus is on work requirements and then the impact to Medicaid. Saran, was there anything you wanted to comment just on the larger picture?
Yeah, I'll also say, these work requirements widely are expanding some of that for a higher age bracket and to a larger population of adults caring for older children. But a lot of the impact here is projected to be felt most heavily on folks who are eligible.
Mhm. Thank you. Yeah, we'll dive into that. So I would say that in my conversations about HR1, what I've gathered is that many assume that the cuts are going to be modest or target to inefficiency. However, that's not necessarily the case. HR1 does really impose some sweeping reductions and structural changes across various safety health net programs. And so specifically when we look at the law and the changes, in addition to the numbers that I covered, close to $1 trillion in savings over 10 years, CBO does estimate that the law will increase the number of uninsured by 10 million by 2034. And Medicaid work requirements are driving over half of that loss. And when we look at the drivers of the loss of coverage, it's really at the core is driven by reporting failure. And so the law as it stands really assumes flawless verification of eligibility at scale is possible. And unfortunately, as we'll look at some cases in the next few slides, historically, we know, and we have evidence that shows that states really can't execute this cleanly. Also, as we'll see, states are going to be able to delegate tasks to managed care organizations for the administration and or the eligibility checking. However, they themselves have struggled with that in the past. So we'll talk about that. But ultimately, coverage now, and when I talk about the changes of the nature of Medicaid coverage with HR1, coverage with the law will depend on ongoing documentation, not just eligibility. So that is fundamentally changing. HR1 also fundamentally is changing this because it's of the frequency of documentation and assessment and the timing, and as well as the different tolerances of verification that they're putting into place. And so verification failure at any point in the delivery chain, whether that's like eligibility or during the redetermination process every 6 months, can equal termination. And avoidable termination immediately translates into PMPM revenue loss for the managed care organizations, which is rarely offset by kind of new enrollment. And so that's really important here, is to think about not only the risks and the impacts to the states, but also the managed care organizations, as a lot of vendors think about, how do I sell, what do I sell, how do I approach a managed care organization, on top of all the budget reductions that they've had to navigate over the last few years. This is going to be a really big one, where they really need to think about how to work through efficiency, eligibility, member retention, member experience, etc. We can spend more time on the managed care implications. Any thoughts or questions on this, or Saran, any comments on just the nature of this law change?
This is great. Thanks, Demi.
Great. One of the other really big components that I wanted to highlight was SNAP eligibility. And SNAP eligibility really does bear the same risks as just general Medicaid. HR1 requires verification at scale that states have never really sustained. And now there is the whole introduction of error penalties. And SNAP error penalties prove that systems are already failing under like the current level of complexity of things. Now we're introducing additional level of complexity, and we're expecting even more efficiency, even more compliance, and less failure, which just logically does not make sense. So states with SNAP payment error rates that are over 10%, will be required to cover 15% of that benefit. That is a huge amount of dollars. And addressing these error rates will be a key cost for states. So, and I'll actually make the point that it goes further than the states, as some of this is going to actually trickle down to the counties. But the key point that I wanted to make here is that the main source of error rates that we know historically is miscalculated income. And so that is an issue that we're only going to see get worse. And so again, as Saran mentioned earlier, these are folks that are actually working, that actually are eligible, that potentially will lose that coverage just because of the additional administrative burden. And so we wanted to highlight some historical cases of what's happened in the past and can we learn from history. So I wanted to invite Saran to comment on the Arkansas pilot in 2018 and what we learned from that experience.
Yeah, so Arkansas had done a 1115 waiver to test out work requirements. As you see on the slide, 18,000 people lost coverage. This was heavily driven by reaching the expansion population, which we cross legislation really is widely regarded as an able-bodied and working population. So these are not necessarily folks who have those frequent touch-ins, check-ins and touch points with their health plan. So awareness was really one of those key drivers.
Great, thank you for that. So at the end of the day, HR 1 isn't just a policy change, it's an operational one, and with some really big risks if proper supports aren't implemented. And again, as the past shows, lots of people did lose coverage, and awareness was a challenge. And then also the income eligibility and verification was a really big challenge for that. And so any thoughts or questions from folks on this?
Oh, turned my camera on, but didn't turn my mic on. This is Jim. I just add real quick that every program, I think, also demonstrated that it costs the states more money than they saved in their efforts to verify eligibility.
Thanks, Jim. I appreciate that comment. That is true. Great. Okay. So one of the things another example that we wanted to highlight of just this history and systemic failure is Illinois actually faces over $700 million a year of cost due to their high error rate for SNAP eligibility. And I mentioned earlier that with the new regulation, there's actually 10 states in the US, including California, New Jersey, New York, Minnesota, where the counties are the main implementation arms. And so, and those states collectively represent more than almost 15 million people, or 35% of the total participation in SNAP. And so ultimately, what will likely play out is that the state will penalize the counties for certain high error rates. And so here we have multiple layers. Earlier I mentioned we have the state, we have the managed care organizations, and then we have the vendors that will talk through various complexities there. But there's also another key stakeholder here, and that's the counties, especially in some of these states that potentially will be affected with this change. And so that's something to keep in mind as you're thinking through selling to managed care, and as you think about how the states are going to think through and create RFPs or issue RFPs. There may be some additional language in there around how to collaborate with counties, or the role that counties are going to play in the implementation of the law. So that's important to keep in mind there. So from our perspective, when I think about this at the macro level, HR 1 really has 3 key areas of impact. There's a clear operational piece regarding compliance, reporting, having the data systems in place, and workforce training and staffing. And then there's the very clear experiential ones where there's going to be people that are unhappy and people that lose coverage, not for the right reasons. And so there's all types of experiential kind of metrics that we're going to see get hit. And then there's also financial, which the error rate penalties are really going to be a big financial hit. And then that avoidable churn from a managed care perspective will be a really big one. So those are the three key areas of impact from our perspective. And so with that in mind, then I wanted to really think through, okay, well, what are the risks for states, managed care organizations, and then vendors who may be selling into managed care? So at a high level, this kind of shows how the risk actually moves through the system. So we start with the states, and for states, the primary exposure is legal and political accountability. Even when the work is delegated to a managed care organization, the state is still going to own the compliance, the reporting, the audit, defense. And so what typically breaks first is the eligibility systems and oversight. And again, we've seen this before post-pandemic unwinding, a very similar situation. And so when systems strain, backlogs grow, errors increase, and then suddenly coverage losses all over the headlines. And the financial risk is going to show up in the penalties and the budget overruns there. So the hard truth for states is simple. It's just that, you know, they own the outcome, even if they don't control every moving part of the execution of this. For managed care organizations, while they don't carry the legal blame necessarily, they will largely absorb the cost. And as I think about managed care, at the end of the day, they're a financial fiduciary. They're really a money manager, and so that's where a lot of the financial risk is. So financial and operational risks are really what managed care organizations are going to struggle with this. And what I'm anticipating really is going to break down first is with that enrollment stability, and then just call center. There's going to be a huge call center impact for managed care organizations. Verification requirements will create that churn, and then that's going to create a lot of capitation volatility for the managed care organizations. And so a lot of them are going to scramble, especially if the state delegates to their various organizations to manage this. They're going to have to scramble and figure out, can I do this? Can I stand up this operation, or do I partner and bring on a vendor that's going to help solve this for me? So there's an opportunity there for sure. However, from a vendor perspective, I would really say that the biggest risk here is delivery and credibility. So have you as a vendor done this before? Have you delivered on something that is so large scale and something that requires near zero error tolerance, right? So that's not trivial. This is going to show up in potentially longer, sales cycles or shorter sales cycles, but with a lot more scrutiny of like the actual solution and previous experience, and do you actually have you sold this before? I'm not anticipating that MCOs are going to partner with startups who are just going to test things out for the first time and going to run a pilot with them. So that is my takeaway for vendors, is that there is an opportunity, but you really need to make sure that you have a tested model that works. Any thoughts or questions on this? All right. Well, from my perspective, really under HR 1, success is going to require ownership, and it's going to require having a clear verification strategy, and it's going to require a very, very ruthless scrutinizing and deciding to build versus buy, especially when I think about from the managed care perspective. And these organizations are going to look for infrastructure platform solutions more than a point solution, as that may actually introduce additional risks. And so I'm really, really excited to have Saran just discuss the solution that she's built over the last few years in the space that aligns with these current risks that states and managed care organizations are about to face. So Saran, take it away.
Great, thanks, Demi. Could we get to the next slide? Great. All right, so giving a quick intro to what Mirza do, what we do at Mirza. So our goal is to help build the connective tissue between work verification and benefit eligibility, and really ensuring that people don't lose coverage just because paperwork and payroll systems, gig platforms, and so on don't communicate. So we've been doing this in childcare for a while now, where we provide this sort of end-to-end Common App or TurboTax style way to apply for this host of different benefits in a single place. But importantly, because childcare has always had work requirements, pulling that information over directly from employment systems. Childcare is also this pretty fantastic place to get started and way to build our chops in part because it is much more fragmented and complex with documentation requirements that vary even down to the county level. So what Demi brought up earlier with county administered systems, that really is our sweet spot. We have partners that we work with across different geographies, including within states where one county will require that you include commute time and one that is right next door does not. So really what we've built here at Mirza is a really simple way where on your phone, in your native language, in under 3 minutes, we help folks identify the handful of benefits they qualify for and then give them that easy automated place to apply and then maintain those benefits. So really beyond that, we're helping make sure that, you know, these sorts of complex verification work that is needed actually doesn't get outpaced by the technology that exists to be able to get in front of at-risk populations. So we're really the only solution and not just benefits access. So offering that sort of single point of unified eligibility, enrollment, and verification. So we have these interoperable data layers that undergird our solution and ultimately address the root cause of avoidable terminations. So we integrate into, you know, like I said, payroll systems, gig platforms, public program data, community data, student information systems, and so on, in a way that would then seamlessly and automatically handle missing documentation that folks need to find on their own, instead of, you know, figuring out the right number of pay stubs and looking for that across whether that's Amazon and Lyft. We really make it simple and automate that access and extraction. We figure out what's the right number of pay stubs. It's all already built into our rules engine. So it's a pretty complete, easy way for folks to meet those work requirement guidelines. And then by leveraging new CMS guidance and federal requirements, we're making sure that our partners, whether those are states or Medicaid MCOs, can stay ahead of policy changes and then really maximize outcomes for the populations they serve. And then beyond this, how we're really focused on driving impact, we fundamentally really just minimize coverage losses. And that's by ensuring we're communicating to members in a way that they're ready to receive. So more than 96% of Medicaid adults have a mobile phone. So in part, that's part of why we are mobile first, and we provide that guidance centralized across Medicaid, SNAP, WIC, and childcare. And it's a streamlined experience that is more compelling to members, but also more manageable for those at-risk populations. We're talking folks who might be facing homelessness or housing insecurity, mothers, folks who don't have English as a native language. Beyond that, we also reduce the admin on care managers and the massive ballooning workloads they'll face by ensuring their members have support from us through that entire process of application, document extraction and verification, and redetermination. And then finally, we take the whole person into account. So this is removing barriers to work like childcare and housing, and enabling more members in the household to be able to increase their work hours and ensure compliance to new work requirements. So we really, what we talked about earlier with Reach in Arkansas is something that we've been largely focused on. So not only do we have a track record in ensuring folks are accessing the subsidies that they rely on, we also have the proof that verification and outreach really is something that can be done to help drive enrollment and maintain coverage. So our rollout with partners, even just light touch, delivers a 33% of eligible member base engagement rate. But through targeted outreach, we've also achieved engagement rates of up to 75% of eligible member or workforce bases. And importantly, we work with a broad spectrum of partners. This is across the board, national employers, unions, and Medicaid organizations. And so we have these various avenues of reaching eligible populations like this Medicaid expansion population. And then overall, what I wanted to highlight here is that under HR1, the best strategy is not instead just relying on frontline caseworkers and staff and overburdening those teams with work. We saw that with Medicaid unwinding previously, that the burden is high, but the ROI is not necessarily there. The best strategy is removing friction before it actually becomes costly. So we would help states and MCOs execute on the operational needs for HR1 without sacrificing coverage, compliance, or credibility.
So to recap, what we just discussed is today we have a few key points in time starting from today that we can really get prepared for what's to come down the pipeline. And so Medicaid work requirements start January 1st, 2027. Granted, there are some there are some pieces of the law, especially around the error rates, that depending on how high the error rate is, there may be certain delays in implementation of the new regulation. So that's going to be something to pay attention to, is what state are you operating in, or if you're operating across states, there may be different timelines where this is going to be important for you to pay attention to. But the key is HR1 timelines are fixed and they're clearly communicated and documented. So that's something to kind of pay attention to and maybe work backwards from, depending on if you're operating at the state level, the managed care level, and or if you're a vendor. And just recognizing that state systems are already strained and that managed care organization budgets are already strained. So, you know, don't wait, really get prepared now, as just waiting could increase that churn, that audit risk, and or lack of clarity, or your ability to really fix the system, as we are all working on that. So we want to leave you with some very clear action plans. We recognize that some of these activities may get drawn out. So this is more of a time to sort of like implement and kind of ensure necessary actions are started. But some of these may take longer for your respective organizations, or they may be shorter actually. So what we recommend is most immediately really assigning that ownership and ensuring accountability for various components and pieces of the law that need to be operationalized. And so really the goal with that is to eliminate any ambiguity of who owns what and who's driving what. When and that can entail really also doing a pre-mortem. That is an exercise that is not often done, but it can be really, really helpful to do so that you can set yourself up for success and also identify the most common points of failure. So I highly recommend that. And or just simply identifying those top 3 failure points that you could be dealing with. From there, the goal is in the next 30 to 60 days is just then, once you have the owners and the accountability and have them working on their respective plans, is having the team really identify what are the unknowns. We talk a lot about known unknowns and unknown unknowns in our line of work, and so documenting as much as you can, and then being able to have those team discussions so that you can identify blind spots is going to be really important. The goal really being replacing your assumptions with tested workflows and really making sure that you're prepared. And then in the 60 to 90 day window, just proving your readiness, show that you can execute and you're not just flying by the seat of your pants during execution, during launch. And so even if you could do some small internal testing to make sure that systems are working properly, that everything's integrated and working as it should be, would be really, really important. And doing a series of stress testing across whether you're operating or connecting with call centers or case management organizations, it's going to be really important that all the stakeholders are in alignment and those where 2 things are coming together, that there's flexibility and all of those processes are streamlined. So that is from a managed care organization kind of action plan at a high level. And again, we're happy to share this after the fact. In terms of if you're a vendor, very, very similarly at a high level is you want to establish the ownership, who's going to own what, where and how does your product touch HR1, anything that has to do with verification, reporting, and again, there's going to be real penalties when there's an error. And when you look at the law, it's not just an error for overpayment or underpayment, it's just any error that takes place. And so it's really important to make sure that errors are reduced and identify your partners early. As a vendor, you should really be thinking about, who do I want to work with? What does my solution solve for? Where does it fit in? Am I targeting states? Am I targeting counties? Who do I really, who am I meant to really help and support with the solution that I built? And then reducing the unknowns. So configuring your workflows to match those of the state or the county, just like Saran said. They've done a really great job collaborating at the county, at the state level with various managed care organizations and employers. So it's important for you to understand who your client is and what their expectations are. And almost for you to be over-prepared. You can't be over-prepared in this situation, to be completely honest, just given the complexity. So, and then I would say, and again, the 60 to 90 day window, really proving your readiness. Try to test as much as you can ahead of time prior to implementation so that things don't break down once you launch. Saran, any comments on this, since you've done it time and time again? What advice do you have for others?
I really love the working backwards, or basically having a pre-mortem to be able to really unpack what are the things that could be going wrong. I think we've certainly interacted with some states that are thinking through every single exemption category. So, every single possible category. For example, volunteer hours is one of those. And that is a small enough segment of the base that is probably not the best use of time. So really, that's really when I think through the focus overall. Think about the largest ways to look at where something may break down, the largest populations to address, and then move backwards from there.
Awesome, thank you. We will be sharing out, so after the webinar today, this will be recorded and available for you guys to reference via YouTube. And then we will be sharing these vendor readiness checklist, state readiness checklist, or MCO readiness checklists, depending on what type of organization you're a part of. We're happy to share these. And what I love about these is that they cover financial readiness, operational readiness, data and systems readiness, member experience readiness, right? So we're looking at this from a variety of perspectives, and just really kind of giving you a head start on here's what you need to make sure that you have into place for you to be successful with HR1 implementation. And again, that's our focus is, and the reason, again, why I started Akros is I just want to make the health system work better for everybody. And unfortunately, it kills people time and time again. And so I'm really excited to share about Mirza and a solution that we know works, and then also equip you all at your various respective organizations in really helping implement this change, and helping make sure that people retain their coverage, and get the benefits that they need. I am just doing a shameless plug. For those of you that are interested, please join us at the next webinar. We're going to be talking about HEDIS and STARS, and how those very complex measurement systems can drive and inform payer decisions when it comes to buying certain vendor solutions. And or if you're wondering, hey, I don't know if my solution contributes to improving STARS and HEDIS, how do you actually measure and quantify that? So we would love to see you there. And as Juliana said, if you have any additional questions around HR1, feel free to reach out to us. We're happy to provide more context and color. And then if you want to know more about Mirza and what Saran's team is doing at the state, at the county, or the managed care level, definitely reach out to her or us, and we'll make the connection. But thank you so much for joining us today.
And to reach me, Saran, so SIRAN, first name at heymirza.com. We're working with a handful of MCO partners to date on a national work requirement strategy, and some excited to be in the trenches with some great state partners. So would love to be able to help share out any learnings.